So here we have a short video. This is going to be on chapter 22. It's the urinary and renal system emergencies. Now, I'll be honest with you, most students are having a hard time with the medical section on the National Registry. Understand that this chapter is part of that, right? There's a group of chapters that are all medical, are going to be seen in the medical system or the medical section. Understand that it's very medical terminology based. You got to know where things are located. You got to know what they're called. If you are doing a test question, you can kind of rule out answers as long as you understand the question. So that's kind of my goal here is to go over these systems and help you with the test. So if you have any questions, please ask in the comments, like, subscribe, all that kind of stuff. That does help out the channel. Let's jump into this. So, just talking about the urinary system, we know that it's like a filtration system. Understanding your blood is constantly moving throughout your body. Blood carries a lot of waste, and that waste gets filtered through your kidneys, and your kidneys actually generates with something called nephrons. I'm not going to get too heavy into anatomy, but your those nephrons generate urine, and urine is excreted through your body and it gets rid of waste, right? So it also manages the electrolytes within your body here. It says it maintains acid base balance within your bloodstream. Remember, we have a metabolic and we have a respiratory system that helps out with managing the acid base balance within your body. Another big thing here is fluid volume. So there you'll see patients that have excess fluid. You might see dependent edema in some patients, and this can be occurring because of a decreased function of the renal system. Okay, they could have a backup in fluids. So some renal system problems that we're going to be discussing today are kidney failure. Right, kidney failure comes in a couple of different flavors. We'll talk about nephrolithiasis, also known as kidney stones or renal calculi. Please know those three terms for kidney stones. UTIs, very common uh, issue that at least I see at my job as a paramedic. And non-cancerous enlargement of the prostate. We'll talk a little bit about prostate issues. So again, I did mention I'm not going to go heavy into anatomy, but there are different systems. Let me move my big head out of the way that you have to know. Um, we got kidneys right up here. We got two of these guys. And right off those kidneys, you see these ureters come down. The ureters basically attach the kidney to your bladder. Okay. So we have ureters that connect the kidneys to the bladder, and then that bladder fills up with volume, urine, right? And the urine needs to be expelled outside of the body through a urethra. And the urethra is basically the pee hole to the outside environment. Okay, let's get after this. So I love it. The first thing it says is safety, right? Take standard precaution to avoid contact with people's urine. Yeah, I try not to get urine on me. Understand that urine is, for the most part, pretty sterile, but at the same time, some people do have bacterial infections, and we do not want to have that kind of contact. So yeah, man, wear your gloves. Says form a general impression, airway, breathing, circulation. I don't need to tell you guys how to perform all these things. We're going to be getting more into how these patients are going to present and maybe some places that you might see them, like dialysis, right? We'll get into a little bit of that. So, the first thing it's talking about with these types of pain that is associated with a renal patient can be known as visceral. And I made sure to put the definitions of visceral on here just because you'll see this on testing, right? There's a difference between visceral pain and periatal pain. Visceral pain says it's a deep pain caused by activation of pain receptors in internal areas of the body. This is very hard to locate, right? Very diffuse pain, typically seen in hollowed structures. It says usually occurs when receptors in the hollow structures are stimulated, potentially stretched, right? This pain often seen in urologic conditions. Again, hard to pinpoint, not like parietal pain. Uh, that pain can be pinpointed. They can say, "Oh, I have pain in my right lower quadrant," right? But this is more, I don't want to say systemic, but it kind of in a generalized area, harder to pinpoint where it's coming from. Now, with regards to a secondary assessment, one thing I do recommend for anyone here who is studying and trying to pass maybe the national registry, or you might be in school and you're just saying, "Hey, I'm watching this video right now because I have a test coming up." Know this stuff. It's easy for me to just sit here and say, "Yeah, man, just know where everything's located." But I'm serious when I say that. There's two different charts when it comes to abdominal locations, abdominal organ locations. We have the four quadrant RUQ, LUQ, RLQ, and LLQ. Remember, this stands for right upper quadrant, left upper quadrant, all this stuff. You see this in EMT school. Please, please, please know how to find organs within the abdominal cavity. This is going to help you tremendously in the medical section on that exam. Now, I like to use glass personally. Starting up here, we have gallbladder, liver, appendix. Over on the other side, I said glass, right? So we have stomach, small intestines, and then up here in the left upper quadrant, the spleen. Right, so glass, I like to use that one, but use whatever one works for you. I put this on here, made sure it was on here because I've had multiple students tell me that this was on their exam as well. So take a look at it. It's not too bad once you look at it a couple times. I would even recommend drawing this on some sort of notepad that you're using to help study for these exams. Um, you might see this on a test near you. So pay pay mind to that. Obviously, the lumbar regions there in the middle, uh, iliac regions on the bottom, hypochondriac regions on the top. And just look at the other wording that gets utilized in this chart. I'd hate for you to pass over this or gloss over it, and then you have it on your national. That would be terrible. And it does happen to people. So, saying for reassessment, electrolyte imbalances can cause rapid deterioration. Make sure we have a treatment plan. We're going to talk a little bit about some of these things that we might be seeing here when caring for a patient with a renal emergency. Big thing here, it talks about pain management. And now I know in previous chapters, when we talk about managing of medical conditions, a lot of the time, man, do we talk about analgesics and pain management. The one thing that I would like to mention to you is there's a lot of different pain management that's out there. And when it comes to like abdominal pain, maybe renal or uh, GI, you know, urinary issues, we want to know what's causing the pain. And why I say that is because let's say that you walk up to a patient and they have pain that's in that general area of the abdominal area, maybe upper urinary system, and we're having a hard time pinpointing exactly what's going on. If you are positive that this is easy to diagnose, maybe the patient is already diagnosed and they're telling you what it is, then you can easily make a decision on how to treat their pain. For example, I can possibly give Toradol, which is a non-steroidal anti-inflammatory drug, to somebody with kidney stones, as long as they're telling me, yeah, I have kidney stones, it's already been diagnosed. What I don't want you doing is just throwing things like Toradol into patients that have abdominal pain because you don't know if they're bleeding, right? And then you give a non-steroidal anti-inflammatory drug that's going to reduce or cause an issue with platelet aggregation. And now this person you're increasing the amount of bleeding that's occurring in this patient. I hope this is making sense. We don't just throw analgesics at patients uh, blindly. Now, I would tell you that opioids are a little bit safer of a choice. Just make sure that we're paying attention to the patient's blood pressure and we're following the rules with any contraindications. Always consider antiemetics for these patients as well. But yes, do I think pain management is important for these patients? Absolutely. And now when we start talking about uh, patients that have kidney stones and some of these other conditions, you won't know what these people are experiencing unless you experienced it yourself. And I have plenty of friends and family who've gone through some of these issues, and they have mentioned to me that they don't wish it on their worst enemies. So understand that it can be extremely painful, probably in the worst pain that they've ever experienced in their lives. So let's be empathetic as EMS professionals or you know, care providers. Starting off with UTIs, this is like one that is very popular, very prevalent in the typically seen in women, right? Can also be seen in men, but understand what's happening here is it's an infection that's occurring in the urinary tract. And there's a few things that we will see in these patients or smell. Um, Painful urination, like a burning sensation during urination, frequent urges to urinate, very common. Okay, so they have the feeling that they have to pee, even though there might not be a lot of urine that's coming out, but the body's constantly trying to flush, right? Possible difficulty urinating and pain because patient can appear restless, uncomfortable. Um, One thing that I do also want to talk about signs and symptoms with UTIs, just because it didn't get described too well, that there are patients typically in the elderly community with UTIs, they can become altered. Okay. Sometimes we have somebody who is normally talkative and easy to converse with, and then all of a sudden they're not. Maybe they might say some things that are like out of the ordinary for them. And this is great to have family members there on scene that can tell us a little bit more about this patient and give us some more history. UTI is a common culprit for these patients, so just be mindful of that. Another thing that it didn't really talk about is the really, really pungent smell of urine when you walk into a residence or somewhere where somebody has a UTI. I pay very close attention to that smell when we walk in. You can kind of pinpoint almost immediately that a UTI is occurring. It's just a really, really strong urine smell. Management here, it says it's supportive. Remember, how is this patient going to be ultimately treated? Antibiotics. So unless your agency or your protocols are allowing you to treat with antibiotics, we are treating nausea, vomiting, right? There's not much that we are doing for this patient. Okay, take them to hospital. Okay, so many patients are hospitalized for urinary conditions or disease receive catheterization with a Foley. Understand that. Patients that have urinary retention, urinary issues, they need a Foley catheter where a plastic catheter basically gets inserted into their urethra, and that pipe or that catheter allows for urine to continuously flow without the patient having to urinate. One thing about these ureter catheters that we as paramedics or even EMTs need to know is we're going to be running some of these patients that have them at home. So some of these patients might be um, maybe in a bed, and you'll see the urinary catheter, the bag on the side of the bed. Pay close attention to that because when we move these patients over, we don't want to spill that bag. We always want to drain it before moving the patient. You also always want to keep it lower than the patient. Keep the bag lower than the patient at all times because look what would happen if I bring the bag over the patient. You'll get something called urine backflow. Okay. Backflow of urine. So that urine collects into a bag. I lift up the bag. That urine then goes out of the bag back into the patient. This is not good. Okay. So we've got some issues with this. That's why I always say empty it out. It's not hard to do. So there is a little balloon that's inflated in there, like a cuff, just to keep it inside the urethra. Please do not pull on the ureter catheter or Foley catheter. This can cause some internal trauma. Sometimes I've seen multiple patients who pull it out themselves before we get there, and there's bleeding coming from their genitals. Just note that we try not to do those things. And we want to try to keep the ureter catheter inside the patient. If somebody does pull their ureter catheter, obviously this would require transport. The patient would have to be seen, and they're going to put a new Foley catheter or replace that catheter for that patient. Some urinary obstruction and incontinence discussions. Urinary retention is just as incomplete emptying of the bladder or inability to empty out the bladder. That is urinary obstruction, right? A lot of different causes of this urinary retention. It says kidney stones, uh, AKI, also known as acute kidney injuries, prostate hypertrophy. So the prostate in men is kind of like a donut shaped organ, right? The prostate deals with some uh, has some different functions for like ejaculation and different things, but understand that this prostate that sits around the urethra, so the pee hole of a male, when it starts to get enlarged, it starts to pressure on that urethra. And for you guys that have gone into public restrooms, I'm sure you've heard some men who are in the urinals and they are peeing for a very, very long time. They might after they pee, they even have what they call dribble. So it's just like pee is still coming out, even though they already stopped. This is from enlarged prostates. Okay, so the prostate gets so big that it's squeezing that urethra and causing this very, very long process for people to get rid of urine. Sorry if that was a little too graphic, but that's the truth. That's what it is. Urethral obstructions, UTIs, nerve damage. So a lot of different reasons for urinary obstruction. Now, incontinence just means a loss of bladder control. So somebody who accidentally urinates on themselves. A lot of these patients, they have Depends or adult diapers once they have incontinence because they cannot control when they urinate. So couple different categories here that are talking about urge incontinence, sudden intense urge to urinate with involuntary urine loss occurring within seconds. So it's an immediate, they have to pee and it happens. Okay. They can't control it. The other one's just an overflow. So it's just constantly dribbling over time. It's just an overflow of incontinence. It's just continual flow that these patients deal with. Get my head out of the way here. We're looking at a kidney stone now. Say this little photo here of a kidney stone next to a penny, that's terrifying. Understand that calculi can form inside the kidneys and it needs to pass, right? Because if it doesn't, the kidney stones can get stuck in ureters and cause a lot of inflammation and pain. Uh, and let's be honest, once these stones are passed, it pretty much cuts up everything on its way out. So there will be blood in the urine. And I hear it is not pleasant. I hear it is not pleasant. Okay. Most common stone is called a calcium stone. This is actually 80% of renal calculi. Um, so understand if you ever get a question that says like, what is the most common? It is a calcium deposit. Okay. It says struvites are stones that are more common in women. Okay. That's an interesting one. Uric acid stones and cysteine stones are caused by other elements or electrolyte buildup that so there are not just one types of stone, but again, the most common one that is seen is a calcium stone. Patients always experience pain with kidney stones. Pain may increase blood pressure and tachycardia. Patients may be restless or they may guard the abdomen. Okay, please treat these patients with empathy. Please give these patients uh, Analgesics, pain management, especially if they confirm that this is a kidney stone. Absolutely, we can give these patients Toradol, you know, and even give them opioids. Where we're trying to reduce that pain for them. Here's a photo of a stone. It says patients often presents with hematuria, so blood in their urine, flank tenderness if the stone is obstructing a urine flow. We can see this. Here's the stone in this location, and this urine is backing up, and it is causing some serious inflammation, which is going to be very painful for that patient. Position of comfort, analgesics, establish an IV. Okay, I got some different definitions up here for those of you who are taking notes. I would highly recommend doing so. Okay, it says some stones will pass on their own. Some stones will pass. Obviously, that will be very painful. I do know that when people are getting this treated, they're given like a little mesh that they're supposed to be peeing in to try to collect the stone or the debris that's coming out in their urine. But here's a couple, three different ways that these kidney stones will be treated. Again, this is not by EMS, but this is ultimately the treatment. First one, extracorporeal lith lithotripsy. Lithotripsy. It's a high energy shock wave that'll break up the stones from the outside of the body. Okay, so they'll use a high energy shock wave. Amazing, right? It'll result in smaller fragments of that stone, and then the patient will basically urinate this out. This might look more like sand, right? They're breaking up this debris inside of that kidney stone, and it's being passed now through the urine. And like I said, I have friends and family who have had kidney stones, and they get this little mesh, and they pee through the mesh, and it collects this like sand and debris. Cystoscopy with stent placement. Let's look at what this one means. It says inserting a small camera through the urethra into the ureter, and then a stent is placed to enlarge the diameter of the ureter to allow for that stone to pass. Absolutely amazing. Okay, so they're trying to get that stone out. They need to find out where it's located within the ureter, and they could do that with a camera. Crazy. Next one, percutaneous nephrostomy tube placement. I know a lot of terminology here. Percutaneous nephrostomy tube placement. Small catheter is placed from the outside of the body into the kidney to allow for drainage of material that's obstructed by a stone. So someone who is unable to urinate, they can go ahead and pass a tube up into the kidney to drain the urine out. So three different ways that they're going to get waste out of a patient that has a kidney stone that causing this patient some problems. Going into kidney injury, remember I said AKI, sudden decrease in filtration through the glomeruli causes toxins to accumulate within the blood. Mortality as high as 70% in critical patients. Wow. Some good terminology here. Oliguria. Oliguria just means a decrease in urine output. Now, what is a decrease in urine output by definition? Less than 500 mLs per day for the adult. Again, write that down. That is a 100% test question. Oliguria, less than 500 mLs per day for the adult. It says less than 0.5 mLs per kilogram per hour. This is how they can calculate it, depending on the size of the patient, including children. Anuria just means cessation, means it stops. No urine output. No urine output. Anuria. Patients will experience with AKI generalized edema, an acid buildup. Okay, acid buildup. So this can be metabolic acidosis and high levels of nitrogenous and metabolic waste within the blood. So a lot of waste starts to build up in the blood because the patient's unable to filter this waste. If left untreated, first thing, volume overload, right? The patient's going to have edema, volume overload, hyperkalemia, increased potassium levels, okay? Uremia, increase in uric acid, Metabolic acidosis, right? Which we talked about. We're going to look at a couple of these as we move on. Toxic buildup, nitrogenous waste salts in the blood will cause an impaired mentation, fluid retention, tachycardia, acid bases imbalance, right? And an increased PR and QT intervals. So we might have see some EKG changes, right, with kidney injuries. Pretty interesting. I actually put a couple EKGs in here to show you hyperkalemia, which we're going to be seeing here shortly. Findings can include dehydration, pale, cool, moist skin, so the patient looks like they're in shock, decreased urine output, darkening of the urine, okay, shows you for dehydration, right? Also seen in rhabdomyolysis, flank pain, altered mental status, and even signs of heart failure in severe cases. Says evaluate the abdomen, check for the presence of ascites. Remember, that's volume or fluid buildup. Assess for flank tenderness, any pains on the sides. Perform an EKG. Look for signs of an infection and shock. Not much that we're going to do for these patients. Okay, supportive, start a line, free for shock, right? We're trying to maintain perfusion on these patients. Chronic kidney disease, this is where it gets a little bit worse. Um, Obviously, AKI is acute. It just happened. When somebody has chronic kidney disease, this has been a long term and it's not going anywhere, right? This patient needs to be treated. It says with chronic kidney disease, inadequate kidney function causes permanent loss of nephrons. And if you remember what I said earlier, nephrons kind of assist in creating a urine, right? Forming of urine for these patients. So these patients are having a hard time urinating as well with chronic kidney disease. Scarring occurs as the damaged nephrons cease to function. So that term uremia got brought up earlier. It says increased concentration of urea and other waste products within the blood. Increased concentration of urea and waste products within the blood. And azotemia, I hope I said that correctly, increased level of nitrous waste within the blood that can develop. So, not good. Says some systematic complications will develop hypertension, heart failure, anemia, and electrolyte imbalances. Patients will present with AMS, right? With some severe chronic kidney diseases, AMS, lethargy, nausea, hypertension, and it says pericarditis and pulmonary edema are common. Pretty interesting. Pericarditis, out of all things, right? Remember pericarditis? I have talked about this in other videos. Um, Concaved appearance, ST segment elevation, and multiple leads. Definitely review pericarditis. Interesting thing about pericarditis is the treatment. Obviously, we could treat the chest pain, but actually leaning the patient forward can relieve some of their symptoms. Management of chronic kidney disease. It says we're not doing it in the field. Remember, these patients are at high risk of pulmonary edema, cardiac disease. We're going to be treating symptoms, right? Make sure you do a 12 lead EKG, provide oxygen if needed. Consider CPAP for patients with pulmonary edema, right? And we're going to treat these patients as we would anybody else with those symptoms. Just remember, if the patient is AMS or very lethargic, we might not opt for that CPAP. End stage renal disease. So this is chronic kidney disease that has prolonged, and now the patient actually needs a basically a kidney replacement, right? It says results in untreated acute or chronic kidney disease, right? It's just been prolonged. Kidneys lose all ability to function. Toxic waste materials are now built up in the blood, fatal unless treated with dialysis or a renal transplant. Okay. End stage renal disease, these patients are on dialysis or they will uh, have a high chance of mortality. After dialysis, the patient will exhibit weakness and dehydration. One thing about dialysis is understand this that patients that are dialyzed, which might be every 2 to 3 days, they will be on a schedule and they're there for a long period of time. And it's unfortunate. These people, they get put on these machines where their blood basically gets filtrated through a machine, and that machine kind of acts as the patient's kidneys. So they might be in that place for 5 hours, 2 to 3 times a week, and they become very weak after dialysis. So when we do run these type of calls, we always want to know what is their time frame of dialysis. Did they go? Have they missed any days? We have to have questions for our dialysis patients because we need the full story, right? It says if a patient misses dialysis, they can have signs of fluid overload. Pay attention to shortness of breath. Some other signs and symptoms of end-stage renal disease, uremic frost. I recommend you Google that. Uremic frost. It's pretty interesting. It's like it looks like a dust I get that forms on the patient's skin. Muscle twitching, coagulopathy, chest pain, confusion, seizures, coma. Right? These patients with late stage, end stage renal disease, um, they're in bad shape. Right? They're in bad shape. I understand this. Whenever we get a patient with end-stage renal disease, these dialysis patients, we always want to perform a 12 lead EKG because we're looking for signs of potential hyperkalemia. Hyperkalemia. So let's take a look at this EKG that's behind me. I have what's known as peak T waves throughout the EKG. I'll take myself off so you can take a look. What we're looking at for peak T waves is once I start seeing multiple T waves that have like a TP shape, right? So they're peaked. That's what I'm looking for. You can see it there in lead V2, V3, V4, V5. Now, with regards to height on um, T wave abnormalities, typically in the limb leads, that's the left side of that EKG. One, two, three, AVR, AVL, AVF. Those are limb leads. I typically want my T wave to be below 5 millimeters, right? One large box. With regards to my precordial side, it's typically I want these T waves to be under two large boxes, 10 millimeters. Uh, But you can see that these T waves are a lot larger on this side, the precordial side versus the limb lead side, and that is normal to see that I'm gonna have taller uh, T waves. But what's not normal is that peaked appearance. Okay, sign of hyperkalemia. Now, with patients with hyperkalemia, we need to consider the use of calcium chloride. The dose of calcium chloride is 500 milligrams to 1 gram. And we need to consider the use of sodium bicarbonate, 1 milliequivalent per kilogram. Now, understand this with those two drugs. We do not mix those two drugs together. If you mix those two drugs together, they'll calcify and they could cause some serious complications for your patient. So I recommend do two separate IVs if possible. If it's impossible to get two separate IVs, uh, we're going to have to make sure we flush a lot of fluid in between the two drugs. Okay. Let's take a look at if this progresses. All right. We have peak T waves on the monitor. You didn't notice it, or maybe the patient never called 911 and you show up and this is what you see on your EKG. What we're looking at here is called sine waves. Now, I know some of you might be looking at this and saying, no, this is VTAC. And you are not wrong, right? As long as it's greater than 100 beats per minute, you are right. This is considered ventricular tachycardia. Um, but this is known as sine waves. So typically we won't see this tachycardia greater than 150 beats per minute, right? It's going to be a slower VTAC, and these sine waves develop from extreme hyperkalemia. I'll be honest with you, most hyperkalemia that I've seen that has progressed and the patient has gotten worse, I've seen more bradycardias, but this is definitely a possibility. So the seeing VTAC can be a sign of severe hyperkalemia. Same treatment, right? We got to consider utilizing calcium chloride and sodium bicarbonate. Jumping in, some management it talks about treated is limited to renal dialysis and kidney transplant. So this is how do they treat end-stage renal disease? Not necessarily how do they treat patients with an abnormal EKG. This is treatment of the actual end-stage renal disease is the patient needs dialysis or they need a kidney transplant, period. All right. Nothing really else that we can do. We already talked a little bit about this renal dialysis. What does it do? It actually just filters out blood, removes that toxic waste, brings back normal electrolytes, and the patient moves on. Now, there's a couple different ways of dialysis. One is peritoneal dialysis in through the stomach, and the other one is hemodialysis through the blood. Two different kinds. Patients have vascular access through fistula or an AV shunt. Please understand what a fistula is in this point, or it's basically attaching a vein to an artery. Now, if I can express anything about these fistulas, you're going to see a big bulge in the patient's arm. Please do not put a blood pressure cuff on that arm. You damaging this fistula can be very problematic for you and for the patient. If you cause a rupture of this, remember, this is an arterial bleed. Be mindful. Do not mess with the shunt or the fistula. Just use the other arm, right? Start an IV on the other arm. Uh, this is not technically access for us. Dialysis done in the hospital, it says every 2 or 3 days for 3 to 5 hours. All right, can you imagine having to sit there every couple days for 5 hours to get your blood circulated through a machine? You have to have empathy for these patients. It's a tough life, man, and I'll be honest with you, a lot of these patients are depressed. A lot of them get burnt out. I have met a lot of patients who even stop going because they're just over it. So it's something that you're going to see in this type of patient. Peritoneal dialysis, there's several different types, or well, several, only a couple different types. Understand that this dialysis does go through a shunt in their abdomen, continual, ambulatory peritoneal dialysis, and the other one's just uh, ambulatory peritoneal dialysis. Two different types, and again, they're being dialyzed through their stomach. I do not see this one as common as the uh, blood dialysis. Some complications of dialysis, we talked about them: hypotension and shock, potassium imbalance. Remember hyperkalemia? We get to see those EKG changes that I showed you guys a little bit earlier. Disequilibrium syndrome and air embolisms are two different things that also we can note in these patients. This concludes talking about dialysis, man, and talking about renal disease, renal failure. Understand these patients can be very, very sick. What I recommend for you, though, is to know the EKG changes, know the different names of the issues such as UTIs, how our patient's going to present, kidney stones, and then three different names for kidney stones, how the patient's going to present, how we can treat these patients, and know a little bit about that renal dialysis and end stage renal disease, because you will see questions on this. I promise you. I hope this helps. If you have any questions, please feel free to ask, and I will see you guys in the next one.